activity. We have a total of 137 patients in the hospital right now. Census is holding at about 54% of capacity. Yesterday we had 109 patients in the emergency department, continuing our pattern of very low activity. We would be nearly double that on most typical Tuesdays this time of year. So we see evidence that the community is staying home, sheltering in place, taking care of themselves at home. Testing wise, in the community, we've done 169 cases where test samples have been taken and sent off. Very few results still, including those 2 new positives yesterday. We continue to expect that any day now we'll have a significant number of results come in, but that has not yet happened. Also within the hospital, we have, as we've told you the past couple of days, we have 2 units where we're cohorting patients who are persons under investigation, patients whose signs and symptoms are suspicious, but for whom we don't have a confirmed test result yet. Those numbers right now in the critical care unit component of that cohorting, we have 4 patients. 3 of those are on ventilators. In the medical surgical component, the less severe, we have 11 total patients. So a total now of 15, same total number as yesterday. The numbers have moved around just a bit. Total in the house, we have 7 patients on ventilators, and remember that we have a total of 44 ventilators that are full service and 37 more that are temporary use disposable ventilators. So ventilator capacity remains strong. One of the issues we've had that I've reported in the past has been phone capacity. We are continuing to advise people that if they have concerns about their condition, the best way to access advice is through our 6-8 nurse telephone triage line. That line has been plagued with some shortages of capacity as the numbers of calls have gone up. As of last night, we've added significant capacity to our phone lines. We're continuing to work on a project that will dramatically and permanently expand phone capacity here, but people should have better success getting through to 6-8 nurse today than they have in the past, and we encourage people to continue to use that telephone nurse triage hotline, 6-8 nurse, if they have symptoms, if they're concerned about needing to be screened for testing or any other medical advice that they may need. Including behavioral health advice. If you have a mental health concern, 6-8 nurse is also an excellent resource to help you begin to deal with those issues. We're optimistic now, a little bit more than we have been, about the arrival of personal protective equipment. We've had a tremendous response from the community. We have a daily collection site that is stood up between 10 a.m. and noon each day at the Legends office complex near the Scarborough Sports Complex on the west side of town. Our team is out there for 2 hours a day, and both days so far they've had significant donations come in from the community. We also have an order on the way of a significant supply of N95 respirators, which we expect to be here within the week. That is a big comfort. Certainly is not enough for the long term, but it's the first significant order that we have confidence will actually arrive for a while. So we're encouraged by that, continuing to source other opportunities to add to our personal protective equipment supply because as the numbers grow, we are confident we will need it. One thing we heard yesterday from the state, which is good news, on the DSHS, the state's Department of State Health Services website, the DSHS website. There is a link to a tool that the CDC has published. It's a symptom self-checker. So for patients who are concerned about what may be happening with themselves or a family member, this is an easy, quick way to evaluate your own condition and get advice without even having to interact with anyone via the CDC's self-checker. I would encourage people to check the DSHS website, look for that link, and try the self-checker if you think you need to. That, I believe, is all the updates that I have to offer for this morning, and I'll be happy to address questions at this time.
Can you give us any more details about when the patient died yesterday and just a little bit about who he was?
I can't. What's been reported so far about the patient is the extent of the information that we'll be releasing. We had interaction with his family yesterday, and we agreed with them that no further information would be shared about the patient or his life. He did die during the day yesterday.
So waiting on 169 test results to come back?
We have a handful of, we have 7 or 8 of those back, so the vast majority of them are still outstanding. That's right.
So that being said, is there a possibility for local lab testing?
Yes.
Something that you guys are looking into?
Yes, we have, the question is about local lab testing. We do have one, you've heard on the news talk about a 45-minute turnaround test. That particular test is produced by a company called Cepheid, or I think I'm pronouncing that right, CEPHEID. We have their equipment in our lab, and we have an order in process for about 1,000 of those tests that would come to our lab and be available to us within a few days. 1,000 tests isn't going to go very far, as you can imagine. So we've had some internal discussion about policy for using that testing capability, and at least initially we're going to limit the use of those tests to patients who are in the hospital and to our exposed employees. Once we see how rapidly we use that first allotment and get a sense of how fast we can get the second allotment, we'll consider whether we can broaden that testing capacity. But in the near term, we'll be focusing on patients we're actually caring for and turning around their tests as fast as we can. There'll be more to come on that. We want to be sure that we actually receive those tests. For many of the orders we've been placing for a variety of things, we're finding that we may order 1,000 and get 400 as suppliers struggle to keep up with the demand. So we want to be sure that we actually get what we ordered and be careful with allocating those to be sure they go to the patients who need it the most and need it the most promptly.
Do you have an estimated delivery time?
There's always estimates. We've been told as soon as late this week. I would expect by early next week we should be confident of them being here, but you really can't be certain of that just yet.
Last night, Dr. Wilson put the count in the COVID wards at 11. Can you tell us about the people who have been put into the wards overnight?
The numbers change more often than once a day. As I mentioned earlier today, there is not any confirmed case. So the people we are putting into the med-surg ward and to the critical care ward are showing signs and symptoms. They're sick enough to be in the hospital. As we said, 3 of the 4 patients in the critical care space are on ventilators. Those patients are being carefully controlled each day in consultation between Dr. Wilson and the attending physicians involved to determine who's appropriate for those cases. But in general terms, people who are suspicious, who have manifested symptoms that are consistent with the disease and for whom we've not found another source of their disease are being put into those units out of an abundance of caution, and so that we can keep the staff together who are caring for these high-risk patients.
Well, I guess I'm curious, were those people who started manifesting symptoms that walked in yesterday, or were they people already in the hospital? I
don't know the answer to that. I'll ask Kit to come up and see if he can tell you any more about that. Obviously, we're going to be somewhat circumspect about what we share about any individual patient, but he can give you a more global idea. This is Kit Bredimus, once again, our Chief Nursing Officer. Kit?
Yes, so just like normal hospital operations, we'll have patients that move into these units from various different units, but we also get some from that manifest either through the ER and then get admitted into the hospital. At this point, it is a fluid situation. We also move patients from our critical care area that have improved to our med-surg area as well. So that's why there's a little bit of differentiation in those numbers, because we do move patients from those units, if that answers that question.
Right. Hard to be real specific about that, but in general terms, that's how it's working day to day.
Are you all testing patients in the ER or only patients who have been admitted to the hospital?
The question is, are we testing patients in the ER or only patients who have been admitted to the hospital? We have testing happening in a variety of settings, but I'll caution you to remember the first thing is that what we're doing is sampling. We're taking nasopharyngeal swabs, capturing a sample, and then packaging that up and sending it to an off-site lab. We don't have any on-site testing. So when we say we're testing, what we're really doing is taking samples and sending them for testing. That does happen in the ER. The most frequent site is our off-site testing center that we've made accessible to patients who are referred by their physician or by 6/8 nurse after having been screened for exposure and appropriate symptoms. That's still a limited population, but that's the most frequent. And of course, anybody who's in the hospital and shows those signs and symptoms, we capture a sample and send those off as well.
So I think yesterday it was a little shocking to see that man didn't have any pre-existing health issues. What would you say to the community who have maybe been brushing this off as, well, I'm really healthy, I think I'll be fine, and then they see a case like that where 60 isn't that old and to not have any pre-existing health conditions, I think kind of scary for some people. What would you have to say to them?
I think that certainly the death of any patient is a tragic situation, but it does serve to illustrate for the people in the community who may not be taking this seriously enough that this is a very challenging disease. It has led to mortalities not only here but around the world. They're not frequent. We're still trying to get a handle on what percentage of patients are likely to die, but it's significantly greater than zero. And for any of us who are not taking this seriously yet, I hope this is a wake-up call. You heard the mayor last night. You've heard him every day for a while. You've heard the governor and others caution all of us to stay home, to avoid crowds, to practice very careful personal hygiene, especially hand washing, and avoid touching your face. To practice social distancing if you're in a grocery store or any other environment where you need to be out, but really only to be out when it's really essential. Those things remain in place. They are still the best possible advice. Even the president's original 15-day order is still in effect. We're still trying to get through the first couple of weeks of severe restrictions on movement, and hopeful that will reduce the spread of the disease. But once a patient is infected, not everybody has severe symptoms. Many people can get through this. In fact, the vast majority of people get through it without any significant insult. But for those few for whom it gets very severe, the patient can go downhill fast. They are often ending up on ventilators, and anybody on a ventilator their ability to recover is challenged. And so we have to take this very seriously. I hope people will hear that.
We have a few questions on Facebook. Do we get to find out where this patient, the confirmed case that we had, has been, or where they went?
The question from Facebook is, will there be any more information forthcoming about the confirmed positive patient and where he might have been exposed? We've said from the beginning that this was a travel-related event. I don't think we know a lot more than that. The health department may be able to share more in the future, but we do believe it was domestic travel. We can say that much.
Does anyone know how they are treating these types of patients, or is it just keeping them comfortable?
The question is, does anyone know how we're treating these patients? It obviously is being managed by expert physicians in critical care and in infectious disease. Those treatment regimens are the product of their professional expertise. Kit, you maybe want to comment any further?
Yes. So again, it's going to be based on symptom management. So the severity of the disease varies by person to person, just like the colds and everything, any other virus that's out there. So it is going to depend on the patient what particular methodology we're going to use. We are using the latest recommendations from the CDC and various experts as to how we're going to treat each individual case. But again, recognizing that it's not a one-size-fits-all. It's going to be varied by patient to patient.
Very good.
Have you acquired some of these drugs that are anecdotally have appeared to be helping, and will you be offering the victims in severe condition the option of taking it?
That's been a common question about the drugs that have been talked about in the popular media, the anti-malarial drugs. Kit, would you like to comment on our use of those?
Yes, so we are currently looking at utilization of that along with the azithromycin and the anti-malarial drugs. Right now, again, it's still very anecdotal evidence. There is some research that is suggesting that there is a positive effect to that, but as of right now, we're being very judicious in using those treatments, and again, it's going to be in the more severe cases. We're not recommending just routine treatment for every patient.
Recognizing there is a judgment involved with the physicians each time that a case comes up, there are also side effects of some of these medications that they have to be thoughtful about managing should they choose to use them.
How many Midland Memorial staff have been exposed to the coronavirus while treating people, and have any of them started exhibiting symptoms?
The question is how many of our staff have been exposed. I don't know the exact number at this point. Early on, we had about 30 people that we were confident, we were concerned had been exposed to our first positive patient prior to recognizing that he needed to be isolated. Our employee health group has been monitoring those patients, they're not patients, those employees. Most of them have continued to work with masks and with regular monitoring for symptoms. I know that at least a couple of them have had some symptoms and been asked to stay home. Beyond that, I don't know any numbers beyond those original 30.
I guess when someone's been exposed to something as infectious as COVID-19, how do you decide who continues to work and who is sent home?
The question is about exposure for employees and how to decide who should continue to work and who should not. Early on in this process, we asked for and received guidance from the CDC, recognizing that the healthcare workforce is going to be essential to managing this crisis. And if we send home everybody who's had any level of exposure, we will quickly have nobody left to care for patients. And so early on, we determined that our staff who may have had an exposure or who have had an exposure to a patient could continue to work with a mask, would be monitored on a regular basis for temperature and other symptoms by our employee health group, would be sent home if they began to manifest any symptoms, and we've stuck with that policy so far and expect to continue to do so.
Yeah, and just to add to that, we are following CDC guidelines as far as exposure control. If we do have a suspected exposure, we are following those processes, and every employee, regardless of exposure risk, is self-screening every day, making sure that we're reporting any variants to our employee health department as well.
What kind of protective measures are you taking with employees that you believe have been exposed?
The question is what kind of protective measures are we taking with employees we believe to have been exposed? If they've been exposed to our one positive patient, so they're a known exposure to a known confirmed patient, then we're taking the precautions I mentioned earlier. We're monitoring for them for symptoms. We're allowing them to continue to work with protective gear on. If they manifest any symptoms at all, we're sending them home to self-isolate. Of course, if they get sicker, they'll be in the hospital. For employees who have, and this has really waned, but in the beginning, people who had traveled to countries that are on the level 3 risk list or had any other exposure outside of the hospital, those folks were asked to self-isolate and stay home for the 2-week period that was requested by the CDC. We expect to continue that level of precautions for now. They seem to be working, and we'll continue to monitor that on a daily basis.
I guess can you go more into detail about the protective gear that these employees?
Effectively, we're talking about masks. When an employee has been exposed, when anybody's been exposed, wearing a mask themselves is intended not to protect that person, but to protect other people, to prevent secretions of droplets from their own respiration from affecting the people around them. So with an isolation mask on, they can continue to work safely as long as they don't have any symptoms.
And just to add to that piece as well, hand hygiene is still the single most effective method for infection prevention. So we still want to continue to stress that. I know there's a lot of talk around the masks and how to use the mask, and that is a good source control, is to wear a mask if you're coughing, but ultimately washing your hands is the number one mode of which contamination occurs. So.
That's right. Washing your hands thoroughly, using 60% or greater alcohol content gels or other disinfectants. cleaning surfaces. We do believe that the virus can live on surfaces for some period of time. So if if you're in my office now, it smells like bleach. That's common around the hospital. Should be common in any public space where we're using useful disinfectants. And if you can't get Lysol or the other commercially available disinfectants, a bleach solution will do the job, and that's what we're commonly using in our administrative spaces.
We're being asked for clarification on how many tests have been taken versus how many results that we have received.
It's 169 cases that are tests that we have taken. I believe the total number of results is now up to 9. We were reporting 7 yesterday. We had 2 come back during the day yesterday, so I believe we're at 9. So obviously a very small percentage of the total that are outstanding. We're continuing to hope for a large number of those to come in at once. And we're obviously concerned, we're seeing this in other places, when we get a large number of reports back, and if a couple of those are positive, it's going to look like we've had a significant jump from one day to the next. We'll recognize that this is about 2 weeks worth of testing backlog, so it doesn't necessarily mean we've got that many new infections. We're confirming ones that already existed. Hopefully that's going to happen today or tomorrow, but we don't know.
Are N95 masks washable?
Washable.
No. The short answer is no. We are taking different methods to try to increase our use and utilize our use as best as possible. But no, as of this point, they cannot be washed.
We can do a little bit of surface cleaning. We know that the droplets, the virus in the droplets, will die if the mask is left to dry, and so reuse we've limited to 3 or 4 days.
4 days of continuous use, or if they are visibly soiled.
And remember that the N95 mask is used only with a single patient. So and it's only used with isolation patients. So if you're caring for a patient in critical care, in isolation, on a ventilator, you've got an N95 mask that you can use for that patient, leave in the room, reuse for 3 or 4 days, but they're not worn from one room to the next. They're not exposed to more than one patient. That's been our rule from the beginning.
With your announcement that you guys are feeling better about your PPE supply, should people take it as that you guys are all good, or do you still want them to continue donating?
No, the question is about the PPE supply. Should you take from my remarks that everything's fine and we've got plenty? No, you certainly should not. We've got an adequate supply for the patient population we're caring for today and for several weeks at the load of patients that we have right now. That load could increase dramatically at any time, therefore challenging that supply of PPE. So we are continuing to try to source PPE from a variety of places. We expect those numbers to grow in the days to come, but if we find ourselves with several more patients tomorrow, we'll deplete those supplies pretty rapidly. So we're not going to become complacent, but rather to continue looking for PPE. We know the federal government has been engaged, and the president has engaged the Defense Production Act, which requires some manufacturers to step up production at the government's request. We're expecting that and voluntary commercial efforts are going to increase the supplies available to us, but that's still a day-to-day work in progress.
Do other patients and guests at the hospital need to self-isolate after visiting the hospital?
Do patients and guests at the hospital need to self-isolate after visiting? The answer to that is no. If you've been exposed to a known confirmed case, or if you've been to a high-risk country, then you should be self-isolating for 14 days after that exposure. We are allowing very few visitors to the hospital, and those visitors are seeing patients who are not suspected of having the virus. So there's no reason to self-isolate. There are great reasons to minimize your stay here, to wash your hands carefully while you're here and after you leave, to avoid touching your face, to do all of the protective activities that we recommend for everyone. But otherwise, simply being in the hospital building or seeing a patient who is not suspected to have the COVID-19 virus is not cause to self-isolate. Anything you want to add to that?
No, that's exactly right. Again, The recommendations for self-isolation remain the same, whether you have gone to a hospital, HEB, it doesn't matter. It's going to be based on symptom management. It's going to be based on whether you've had known exposure to someone who has tested positive for COVID-19.
Do you plan to restrict L&D spousal support in the next few weeks?
The question is, do we plan to restrict L&D spousal support in the next few weeks? We are restricting it now on some level. We have had laboring mothers are one of a small handful of categories of patient for whom we are allowing a single visitor, a single support person. But that support person has to be screened. They have to be disease-free, they can't have a fever, they can't have a recent onset cough. So we have to be very thoughtful that they are healthy when they attend a delivery. And it's only one person now. In addition to that, we allow one parent with a pediatric patient. We allow a limited number of family members to visit an actively dying patient. And for our primarily elderly patients who cannot speak for themselves, who have a guardian or someone who has power of attorney, we're allowing that person to be present for their care. Otherwise, visiting is severely restricted.
Have you tested any residents that aren't having symptoms but have known exposure?
Have we tested any residents who have symptoms?
Who are not having symptoms?
We're not having symptoms. No one has been tested. It's not having symptoms. That's one of the main criteria for getting tested in the first place. You must have symptoms. You must have a likely exposure, and we will rule out other things that might be causing your symptoms. So we're limiting testing pretty severely right now. And certainly if you have no symptoms, you're not being tested in Midland. Now there are places, as we all know, where people who have been reported, public figures especially, have been reported not to have symptoms and yet have been tested. That's uncommon, and it's not happening here.
Are any of the negative tests that you've received, are any of those patients in the intensive care unit?
I don't know the answer to that.
I don't believe so.
I don't think so. Yeah.
Have those tests come back positive for anything else, like flu A or any other respiratory?
Have the tests that our patients have received come back positive for anything besides COVID-19? If they have a positive test for something else, they're by and large not in those units. Is that accurate, Kip?
Typically, yes.
Our working assumption, led by our physicians, has been if there is a clear indication of some other virus or some other disease process causing the symptoms, then that is in all likelihood not a COVID-19 patient, and so we've not tended to cohort them with the suspected patients. So we clearly have a lot of respiratory diseases still that season, but not in the cohorted units.
If going to the grocery store when necessary, can droplets remain in the air for long periods?
There is differing science about that, but I don't think there's any question that at least for some period of time droplets can remain in the air, especially with immediate contact. The 6-foot rule is intended to recognize that it's hard to cough droplets 6 feet from yourself. They're gonna fall and dissipate, and so that's been good advice. But the droplets and the active virus do linger in the air for some period of time. I don't know if we've heard an exact range of time. Have you heard, Kit?
No, it's going to depend on environmental factors. So it's going to depend on ventilation. Outside is different than inside. Whether you're standing next to any kind of air source, we'll factor all of that. But to the base question, yes, it can linger in the air for a short to a long period of time, depending on environmental factors.
Has there been extra cleaning or disinfecting efforts made on the floors for the patients that are under inspection or positive?
So the question is there extra cleaning happening in the rooms where we're isolating patients who are suspicious, right? The person's under investigation. We're aggressively cleaning those rooms. One of the challenges is that we have tried to limit the traffic in and out of those rooms. So while we're being aggressive about cleaning, for the most part, we're limiting housekeeping staff and asking our nursing staff to handle that cleaning, trying to minimize the number of exposures that happen in any given patient. So very serious about cleaning. Certainly throughout the hospital, our housekeepers are being very aggressive, but in the isolated rooms, we're taking even greater care to limit the people that are in and out and clean with only the staff who are going in to take care of the patient.
What are the symptoms for the virus?
Let Kit do that one.
So the symptoms for the virus remain the same, which would be a fever is one of the hallmark factors. It's over 95% of patients would present with a fever. Also a new onset of cough. Really any kind of respiratory lung issues, I think that's where we really need to focus. If you have a cough, you're having any shortness of breath, those are going to be the main factors to look at when you consider whether you're thinking you have COVID or not.
Fever, cough, shortness of breath. People have asked me a couple of times how to distinguish between seasonal allergies and the kind of deeper respiratory disease that we're talking about here. Those of you who have suffered with seasonal allergies like I have know that they begin in your head. The drainage is out of your sinuses. Often a cough is a part of that, but it's not the deep respiratory cough that you get with pneumonia or with these viral diseases that settle into the lower lungs. So it is not difficult to distinguish between those. The presence of fever is a key indicator as well.
If a patient does pass away, are they released to the family for burial, or is it protocol that they be cremated?
That we've had the one patient death, and I'm not aware of any change in post demise protocol. The question was, is there a requirement that those patients be cremated? I do not believe so.
No, there's no requirement that they be cremated.
Of course, we'll notify the funeral home and they'll take precautions, but no requirement to change their practice in any way.
Do you know what kind of precautions that would look like for the funeral home?
The question is, do I know what kind of precautions the funeral home would take? I don't know. You'd have to ask them. We're not familiar with their procedures.
Are Odessa patients being grouped with Midland patients?
The question is, are Odessa patients being grouped with Midland patients? Does that mean within our hospital, do you think?
Yes.
We don't categorize patients according to where they live. we take care of patients based on what symptoms they have and the care that they require. So they could be. I don't know where all of our patients who are in the house live currently. There could easily be Odessa residents among our patients.
Is it safe to be outside in your backyard where there's no people other than your family and get inside without worry about your hair, clothes, or shoes being contaminated?
Is it safe to be in your own backyard without worry about being contaminated? Yes. This is not nuclear fallout or something else that is broadly spread and lingers in the air for extended periods of time. You are safe in your own space. Even if you are near to someone who is suspected, if you stay away from them 6 feet or more, if you're washing your hands and carefully cleaning surfaces, you're not being exposed. So certainly in your own backyard, near no one else, whether they've been exposed or not, you're completely safe.
If you are infected and recover, are you then immune?
That's a good question.
So
I want to repeat the question. If you're, I'll do that. If you're infected and then fully recover, are you then immune?
So that's a term what we call convalescence. If you've recovered from an illness, at this point we are not entirely sure. There is a lot of evidence that suggests that you would be immune to it, similar to vaccinations for flu. That you do have some immunity to it. But again, viruses are unique. They mutate, they can mutate. So at this point, we don't have any firm evidence to that affirmative, but right now the anecdotal evidence shows that there is a high likelihood that you would be immune.
It will take a while for us to really know that for certain. We have to see around the world some extended period where people have been tested positive, recovered, and then had an opportunity to live their lives and see what happens. But we certainly believe immunity is certainly enhanced as your body fights it off the first time. Other questions? Okay, thank you all very much for being here today. I hope the sound quality was better. We'll continue to use this site. I believe we do have a backup plan to move inside if we have to. But would prefer not to. We have an off-site building that's separated from the hospital that might be our alternative location. We're going to try to keep these outside as long as the weather allows it. We'll see you tomorrow. Thank you.